AMR. I hope everyone is doing great. And as we know, AMR is not confined only to human health sector, and we should view it through a holistic lens of One Health. And One Health basically combines human health, animal health, and and environmental sector under one umbrella. So, in this regard, today we have decided to invite speaker from veterinary sector, and he will highlight the importance of AMR in veterinary sector. So, without further ado and wasting your time, I would like to introduce Dr. Ijaz Ahmed. He is assistant professor at University of Peshawar, and today he'll be discussing the topic that is application of PKPD modeling in veterinary medicine. And our second subject matter expert is Dr. Taimur Hamid Chaudhary. He is senior scientific veterinarian at National Institute of Health, Pakistan. So I hope you all will enjoy the session. Over to you, Dr. Ijaz Ahmed.
So my name is Ijaz Ahmed. Hear me? आवाज आ रही है मेरी?
Yes, we can hear you.
Okay, my name is Ijaz Ahmed and I am working as assistant professor in the College of Veterinary Medicine at Agricultural University of Peshawar. The point to deliver is application of PKPD modeling, it is pharmacokinetics and pharmacodynamics modeling in veterinary field. Actually, we know that antimicrobial resistance is the big issue nowadays because the antibacterial or antimicrobial are used frequently nowadays. And there is an urgent need to overcome this problem because the resistance is spreading from the last so many years. And now in this situation, we want to combat against such life-threatening issue. So for that purpose, my topic is related to that issue, that is application of PKPD modeling. So first of all, when we are prescribing a drug, so we should need to do something like we should know about this, especially for doctor or practitioner or microbiologist, that we should know about that the antibacterial that we are prescribing, that is the correct antibacterial which is working against that specific microbes or not. Second, we should know also about the correct dose, that the dose we are prescribing, that is the correct dose or the suboptimal dose or maximum dose. So we should take care also about the dose. Third one is the correct duration, that is the dosage regime. The drug we are prescribing, so for a specific duration, we should prescribe the drug for specific duration. So we should also take care when we are prescribing a drug that this is for that specific duration or not. And the fourth one is the early disease diagnosis. That is, if someone have problem, if we a patient, then we should take care also that the disease is in acute condition or chronic condition. So we will take care of that. After objectives of our study or topic is we should know about the pharmacokinetics, that is PK and PD, pharmacokinetics and pharmacodynamics. So what is pharmacokinetics and dynamics? The pharmacokinetics mostly is what the body does to the drug. That is how the drug is absorbed, distributed, and metabolized and eliminated or excreted from the body. So that is the pharmacokinetics. Second is the pharmacodynamics. Pharmacodynamics is what the drug does to the body. That is how its mechanism of action, and how it interacts with the receptor. So this is all about the pharmacokinetics and pharmacodynamics definition. correlate serum pharmacokinetic parameter for various drug classes with outcome of infection. The main focus is also that we should correlate how drug when we administer, so how it will reach to the maximum concentration, and then after how much time the drug is excreted from the body. So also combine will be the result. Third is pharmacokinetics and dynamics modeling. When we know about the pharmacokinetics and pharmacodynamics, so after there explore, and then we will make a model for dose optimization, which will be used to describe the relationship between dose, concentration, and desired end side effect. Like in the previous slide, I told that we should take care about the dose, that we are using the correct dose or not, the correct concentration, and also what will be the effect. If suppose we are using more concentration, so what will be the effect and what will be the side effect. After that, we will apply that pharmacokinetics and dynamics for early prediction of drug effect. Due to this model, we will also predict different dosage. That is, if suppose we are increasing the dose, then what will be the side effect or adverse effect, or if suppose we are decreasing the effect, so what will be the effect. So that model has also this effect. And the last one is to optimize the dose. On the basis of this modeling, that is the early prediction and its know the proper dose and proper dosage regime for all types of antibacterial drug. Because due to this model, we will optimize the dose by using this model for every group or every antibiotics. Now I'm coming toward the journal principle and methodology of PKPD modeling. Like pharmacodynamics, and now I'm coming toward the journal principle. So what are the principle? This is the figure from my own review paper. Actually, when we are using antibacterial drug, so these three issue have interrelated. Like suppose when we are using the antimicrobial drug, the and the bacteria, these three are interconnected. Like the antimicrobial drug, when we are using, so the host will handle their drug. Like in the host, it will be absorbed, distributed, metabolized, and eliminated, like I told in the previous slide. But if suppose we are increasing the dose, this will produce the toxic effect in the host. Next, suppose the bacteria is responsible for making for infection in the host, like animal, human, they will cause infection. So the bacteria is the responsible bacteria, virus, or fungus is responsible for making or infection in the host. In the host will also there is also natural preventive measure that will be adopted by the host. Like we have I think you have studied about the immune system. So they will or system from the bacteria. And then this is the relation between the bacteria and the host. And the third is the bacteria and antimicrobial drug. On the basis of pharmacodynamics, we should know the efficacy of the bacterial against bacteria, and due to suboptimal dose or overuse, the resistance is spreading. So when we are not using the optimized dose, the bacteria will produce the resistance. So these three is the this is the triangular relationship between these factors, and the whole summary is included in this slide, because these three are interrelated. Next slide. This is also the background. This is the parts of that background. Like suppose when we are using the antibacterial drug, so we should follow the proper dosage regime. And when we are using the antibacterial drug, so the bugs, that is bacteria or virus, they will be exposed to that antimicrobial drugs. And then for that we should also know about the potency of drug. Like for potency, mostly we are using the MIC, minimum inhibitory concentration, from last so many decades. Nowadays we are also using like minimum bactericidal concentration. I'm coming toward it, and also mutant prevention concentration. So this is the parameter which are used to measure the efficacy of antimicrobial drug. And then after that efficacy, they will affect on the host. Like suppose if there is infected person, a human or animal, so will then we should check their clinical efficacy, that the drug we are using, they are clinically effective or not. So this is all about the dosage regime. Now I'm coming toward uh, different pharmacokinetics parameter and different pharmacodynamics parameter. Like before, I told that pharmacokinetics is the body handle the drug. So in the parameter of pharmacokinetics are like absorption, distribution, metabolism, or excretion. How the drug is absorbed, how it is distributed through the interstitial tissue or also to the site of infection, how it is metabolized. Like we know that the drug is metabolized in the mostly in the liver by cytochrome P450 enzyme. Then excreted mostly through kidney, through urine. And other pharmacokinetics parameter are protein binding. Like suppose when we administered the drug, so when the drug reaches the systemic circulation, the blood, they will bind with the protein. Mostly the albumin is present in the blood. Excuse me. Okay.
Everyone, please mute themselves. All the participants.
Thank you. If you have question, then please write, and at the end I will give the answer. Next is serum concentration. This is also the pharmacokinetics parameter. Suppose when we are administering drug or when we take the drug orally, so the drug they will reach the systemic circulation, and then we can determine their drug with the help of high performance liquid chromatography and the serum. So this is also the pharmacokinetic parameter. Half-life. Half-life, this is mostly used in kinetic parameter. Due to this parameter, we should know that the time at which the drug concentration reaches to half of its concentration. That is the half-life of drug. Because for to know about the drug metabolism or excretion, we should also know how time the drug is present in. So for that, half-life of drug is used. Next is the area under concentration time. When we administer the drug from administration up to the excretion, there is some, suppose in 7 hour, 8 hour, or 10 hour, the drug is excreted. So every time, like after every 1 hour, we are checking the drug with the help of high performance chromatography. So the area under concentration time curve all the time at which the drug after administration up to the excretion. This is included in the area under concentration time curve. This is the most common pharmacokinetic parameter. Now the pharmacodynamics parameter. In pharmacodynamics parameter, like how the drug they. So this is mostly in vitro study. I think you should know about the minimum inhibitory concentration. We are using in the mostly in the lab, mostly microbiologists, they are using the minimum inhibitory concentration to know the concentration at which the minimum concentration of drug at which they can kill the bacteria. That is the inhibitory concentration. Minimum bactericidal concentration. In minimum bactericidal concentration, the drug kill 99% of bacteria. That is the minimum bactericidal concentration. The next is mutant prevention concentration. I think this is the new technique, mostly for optimizing the dosage regime. we use this technique. This is same like MIC, but in MPC, we use this for the first step mutant, like we increase the concentration inoculum size of bacteria in for longer duration, not like MIC that is for 24 hour. This is for more than 96 hour. More than 96 hour, we expose the bacteria to the drug. And after that, the inhibition curve is also the pharmacodynamics parameter that we should know the full time. Like for 24 hour, we are using the MIC. So for 24 hour of after every 2 hour, we should know that how much killing occur in the bacteria due to the exposure of that antimicrobial drug. After that, there are some antibacterial group of drug. I'm coming toward that. Post antibiotic effect. That is, after removal of drug, the effect is also present. So that is the post antibiotic effect. Now I'm coming also toward that in detail. So this is all about the pharmacodynamics parameter. So the common pharmacokinetic parameter and the common pharmacodynamics parameter. This is all about that. Next is the this, like suppose after activation, the systemic circulation. So you can see the graph. The horizontal is the time and the vertical is the concentration. So when we administer or host, human or animal, so after some time they will reach the maximum level, and after that they will decline, and at the end they will excrete from the body. The other thing, that the MIC and MPC. Okay, the PAE, at the end, you can see this is the post-antibiotic effect. And when we are using the antibacterial drug, this is somewhat difficult. If you have questions, then please write. But this is important. Like when we are using the antimicrobial drug, so the drug should be above the MIC for longer time. Like when we are using, suppose, so if the drug concentration above the MIC, it will work. If it's below the MIC, it will not work, because this will be the chronic present. So we will be student prevention concentration. MIC, Steph Aureus are antibacterial against their on the UR3. So it for resistance bacteria, those should be above the M longer duration. So this is the main point there to that if suppose the bacteria is they use the drug above the MPC. Now this is the PKPD model. Also the example, like suppose this is also describe the PKPD model in pharmacokinetics, just the time and concentration curve. Means of concentration and time. And the dynamics is concentration and effect. And the PKPD model is the effect and time. The correlation between effect and time, that is the PKPD. PKPD index. This is also a new idea. Suppose using there are different groups. You should know mostly the 5 important groups, like cephalosporin. This is working on cell wall synthesis, inhibit the cell wall synthesis. Which inhibit enzyme, which can affect antibacterial drug is classified into 2 major types. One is the time dependent, the other is the concentration dependent. In the third group is concentration dependent, but it can also, like time dependent, it can also prolong persistence effect. Like suppose I'm giving the example, suppose the ciprofloxacin or ofloxacin, this is concerned, this is concerned, major parameter for this is AU or peak peak MIC to the MIC. So for concern, if is increased maximum level, the effect will be better. While in case of time dependent, like time dependent drug is cephalosporin group, cefotaxime, uh, cefoxitin, etc. They are time dependent drug. So the major parameter for this is time greater than MIC. Like we should no need to increase the dose up to the maximum level just above the MIC. So in case of time dependent drug, we should follow strict, I mean schedule. Like in time dependent drug, the duration is short. Mostly cefotaxime, we should take care that we should give the dose after every 6 hours or 8 hours. Because in time dependent, the concentration above the MIC for longer duration will be better. While concentration dependent, if suppose the drug is after every 12 hour or 24 hour, no matter. But in that case, we need the maximum concentration. So this is the difference between time dependent and concentration dependent drug. This is the example of concentration and dependent. Time dependent beta-lactam, macrolides, clindamycin, vancomycin. This is the time dependent. In concentration dependent, aminoglycosides, fluoroquinolone, and metronidazole, etc. The concentration dependent have also post-antibiotic effect. That's why we can say that its dose for after short time is not necessary as compared to time dependent. Time dependent drug, they have no post-antibiotic effect. And some drugs are also codependent, which have also time and concentration dependent. So we should also give more concentration, or also after every minimum time we can use their drug. So these are the three main types of the antimicrobial antibacterial drugs. This is just example that I have taken this picture from Nature Review. You can see the tobramycin, ciprofloxacin, and tecorsilin. In these three pictures, you can say the tobramycin, ciprofloxacin, they are concentration dependent. In this case, you can see we can use this 2, 4, 6. The 6 is the log-10. This is the MIC, the bacteria responsible for more than 10 raised to power 6 CA2 per ml. The bacteria we are using for MIC. So this is the MIC, and we can use the different concentration. Like at right side, the first is the control, which are not exposed to antimicrobial drug. Second is the by 4 MIC. Like the MIC, suppose is 1 divided by 4, so the minimum concentration. Next is the 1 MIC, 4 MIC, 16 MIC, 24 MIC. This is multiplication. So you can see at the control there is the of the bacteria, the first one. After that, if the concentration is increased, so in case of concentration dependent, there is no growth after 2 hours, and you can see the bacteria killing is more. The bacterial killing is more in case of the tobramycin and cephalosporin. While the tecorsilin, they are time dependent. So you can see that there are in the post antibiotic effect. So again, the bacterial growth continue. Next is this is also time antibacterial drug. So in case of time dependent, you can see the K0, K1, K2. If the concentration is increased above the MIC up to the maximum, no matter, because all the effect this will be the same in case of time dependent because they have no post concentration dependent drug. You can see if the concentration is increased, the effect will be more. If the concentration will after that So after this, the effect will be decreased when the concentration decreases. This is evaluating anti-bacterial efficacy using PKPD modeling. So again, I'm coming to that pharmacokinetics is the serum concentration profile for a time interval and also penetration to the site of infection. After pharmacokinetic study, we will know about serum concentration profile and also penetration, how much penetration occur at the site of infection. The pharmacodynamics study. After pharmacodynamics experiment, we should know the potency with the help of MIC, also concentration with time dependent killing and post antibiotic effect. This is the modeling formula that I have taken from the ML Explore. So for PKPD model in dose, we can calculate the dose. This is for concentration dependent drug. AUC, area under concentration time curve, divided by MIC. MIC clearance, and this is the fraction of drug and the bioavailability. So this formula is used for concentration dependent drug to find the dose. While in case of time dependent, we use the time greater than MIC for longer duration of action. And the third one is WAUC. This is for the whole duration, the weight area under concentration time curve, the whole duration at which the drug concentration above MIC. So these three formula is used for determining the dose of different types of drugs. This is the modeling, PKPD modeling of in vitro data. So different experiment. Also, we are doing different experiment to find the dosage regime or to predict the resistance by static system. That is, the dose is constant. In also dynamic system, the dose is changing after specific duration. And then the PKPD model, when we are using for in vitro study, so the pharmacokinetics model and PKPD model, which are describing the resistance, that is that I told in the mutant selection window. So in that model, we can predict the resistance. And also other is increase, so what will be the effect, or decrease, so what will be the effect. This is the prediction. uh, when we are using the PKPD modeling, so we are also using the different animal model in that also the healthy model or disease model. So first in the pharmacokinetic study, when we are using the healthy model, we will just know about the drug absorption time, its elimination, its half-life, its distribution, while the pharmacodynamics is the endpoint that we will do for inhibition curve or MIC, MBC, etc. In case of disease model, we should also know the immune response, because the immune response will be different in case of healthy as well as in case of disease model. Other model which characterizing the full pharmacodynamics time course or model used for antibiotic resistance prediction and also its minimization, uh, and also show the efficacy of the immune system. Clinical PKPD is the also like same when we are using suppose the disease model. For disease model we will produce the bacterial infection or microbial infection, and after that we will use that dose which were optimized with the help of that PKPD modeling. And also we will know, due to disease model, we will also know better about the drug concentration in the target tissue. Other PKPD effect in patient, like what should we know about the residual limit, also the side effect, adverse effect on different organ. This is the model importance that we will use for this categorization. Uh, PD modeling, this is so some formula, they are so difficult, but I think it's important that we should know the mathematical modeling to know the bacteria, like bacteria time interval in care is like in this model, we will also use the control that after how much time the bacterial growth occur and its multiplication. And B maximum is the maximum number of bacteria. Like suppose in Emax, we should know the maximum concentration of drug which can kill the bacteria, or EC50 is the half concentration of drug which is used to kill half of the population of bacteria. Bacterial resistance. This is a journal that if suppose we want to minimize the resistance, so we should need reduction of never dosage regime, and also the revised susceptibility breakpoint, also new antibacterial drugs, and statistically valid clinical study. Also, for minimization of antibacterial resistance, we should know about the inoculum size, duration of therapy, and effect of the immune system. Prevention from resistance. This is the modification of exposure response relationship. So how we will reduce or increase reducing the cycling and sequential therapy, and also through combination therapy we will use against some resistance bacteria, and also the clinical susceptibility breakpoint, and also mostly the clinician, they should know about the resistance. For future perspective, this is the last slide. More investigation is needed regarding PKPD study, development in pharmacometrics, benefit analysis, also our drug exposure response relationship is important for all bacteria using from the last so many decades. And also we should develop criteria to use all microbial or measurement of multi. Market authorization should also be awarded for limited time. Like suppose antibacterial is used from the last 10 years. So now we don't know about the minimum inhibitory concentration, and also because mostly the bacteria, they are resistant, they already use antibacterial drug. So, and also training of clinical practitioner to understand the PKPD approach. That is the clinician that they should know about the concentration antibacterial drug, and also the time dependent drug that they can use the proper schedule. Uh, that I'm working. Thank you so much. If you have any question, then you are welcome.
Thank you so much, Dr. Ijaz. I think it was a very fruitful session, and you very well elaborated it and made our concepts very clear. Now, I would request Dr. Taimur to further highlight the issue of AMR in veterinary sector and elaborate this topic further. Over to you, Dr. Taimur.
Assalamu alaikum. Bismillah Rahman Rahim. Can everybody hear me? Can you hear me?
Yes, we can hear you.
Okay.
Yes. Yes.
So really grateful to Dr. Ejaz explain very for explanation. So it was concise and brief introduction. So I would highlight issues about the antimicrobial resistance settings. So, outside. Okay. So, when we talk about the antibiotics and antimicrobial resistance, there are another species of animal kingdom who are also responsible for acting as the reservoir of antimicrobial resistance. So it is basically the interplay of various ecologies, which ultimately permits the dissemination of antimicrobial resistance in human to animal, animal to wider environment, and wider environment back into the human and animal. So there are certain associated factors, just like infectious diseases, zoonosis, human-animal relationship, foodborne. So these factors permits not only the infectious pathogens, but also facilitates the transmission of mobile genetic elements carrying with them antimicrobial resistance genes. So consumption of antibiotics is quite extensive in developing countries due to large population of livestock and poultry. So to curb this alarming issue, we need to have a multi-sectorial coordinated approach, such as One Health to address this warning phenomena. So there are few points about the significance of antimicrobial resistance in veterinary setting. As everybody knows about the lack of awareness and information about the antimicrobial resistance at farm level. So also there is a lot of practice of prophylaxis medication of high group of antibiotics, just like fourth generation phallosporins and even that colistins, to treat only the basic diseases. Also, the metaphylaxis and prophylaxis is very common at farm level, and even that the conventional level also. There is also the lack of substitution of antibiotics in the market. There must be improvement needed regarding the development of One Health integration between human and animal. That would be possible by minimum the risk of onset of disease by using the antibiotic alternatives such as probiotics and enzymes. There should be a stop on the undiscriminated use of antibiotics over the counter sale of antibiotics is also one of the prime reason for the development of antimicrobial resistance. So so these are the factors which lead to development of the antimicrobial resistance in veterinary settings. So situation regarding antimicrobial resistance in veterinary is much more meager in low and middle income countries. Same is the case in Pakistan. To develop a pragmatic and useful prediction, we need to have adequate data regarding the dynamics of antibiotics, how they work. There should be a proper modeling of PKPD, PKPD approach before introducing a new antibiotic in the field. So because it is eventually it is a very useful tool for a proper application of antibiotic. There are few things about the PKPD modeling. Since AMR is at highest priority of WHO, European Union, and US risk management. Risk take place due to acquisition. The risk of antimicrobial resistance it usually take place due to acquisition of new antimicrobial resistance genes, and these particular strains or the pathogens ultimately travels into the human health, and it happens in a one health approach. So the PKPD modeling is a need of the time in the veterinary field also. Therefore, it is suggested to used in the preclinical and clinical trials before the development of the new veterinary drug to optimize the drug strategy, and that would be possible by the coordination of pharmacists, researchers, microbiologists, that would ultimately coordinate with the clinicians to optimize the dose and treatment duration. So that's all, I think so. If there's somebody have curious about the resistance pattern of veterinary field, I'm all here to respond. Thank you so much.
Thank you so much, Dr. Taimu. That was very useful and very elaborative. Now, there's a question from you that from Mr. Saifullah, that what are the main elements or factors which are responsible for resistance gene transfer among human, animals, and environment? If you can give some example about it.
Sorry, I'm having trouble hearing you. Can you say it again?
What are the main elements or factors which are responsible for resistance genes transfer among human, animals, and environment?
So, the main approach of dissemination of resistance among these three factors, which we called as the One Health approach, it usually happen in two pathways. The very first is the common pathway, which is a human-animal relation or human-environment relation. Whichever the very known example of this is foodborne. Uh, if there is if there's a resistant pathogen exists in the veterinary field, and it ultimately comes into the human health by foodborne, it can go through the zoonotic, and the human-animal relationship, the outbreak field. Also, the other thing which is also responsible for the dissemination of antimicrobial resistance, it is called as the horizontal gene transfer. Uh, we all must know about the plasmids. So they ultimately jump from one bacteria to another bacteria, and they when they jump from one strain to another, they ultimately carry some resistant genes. So these are the some pathways how a human health can develop a resistance from a veterinary side.
It was a very elaborative. Thank you.
That's it.
Then there's a question from Mr. Tayyib Rehman. Since he's a beginner in the field, so he wants to know that how we can tackle AMR in livestock and how the subjects related to drug scheduling, doses, frequency, how they can be addressed, and how our pharmaceutical companies and how Drug Regulatory Authority of Pakistan can play a role in this regard. So, Dr. Ijaz and Dr. Tempur, if anyone of you would like to answer the question.
Uh, I think so. I think so. I would take about the first portion of the question. Uh, it was about. Let me read it again. Where is it? And it is from Tayyib Rahman. Okay. So how we can tackle the AMR in livestock, as most of the resistance come from this sector in our environment. So yeah, uh, as I told in my short introduction about the AMR significance in veterinary field, I told some points. The main reason of AMR development in livestock is lack of awareness. The farmers are not known about the how the pharmacodynamics and pharmacokinetics of a drug. So it is very common they are using antibiotics for FMD, like foot and mouth disease, which is purely a viral based disease. Uh, Managemental diseases. In managemental diseases, the veterinary practitioner, they usually recommend the antibiotics whenever it comes to the health of the animal. The very first option comes into the mind is the antibiotics, uh, which uh, which ultimately which ultimately results into the resistance of penicillin group in livestock. There are very few limited options now in veterinary field. Everybody must know about the mastitis. So the onset or the progression of mastitis is also a best classic example of antimicrobial resistance, because they are using the very undiscriminated prescription of antibiotics. Also, they are also using the antibiotics as a growth promoter, and for the metaphylaxis and prophylaxis. Let's say if one animal is infected from some disease in a herd, so they eventually inject the antibiotics to hold the herd. So this is only the very one example. So there are number of examples like this. That's why that lead to the progression of resistance in livestock. I think so. I I have tried to answer your question. The second part about the PK modeling, that will take about the Dr. Ijaz. I think so.
Uh,
Is he here?
Okay, I want to add something. Actually, the antibacterial mostly they are used in the developing country like in Pakistan, Bangladesh, India, and especially in veterinary field we are using so much. We are mm, I mean the overuse of antibacterial drugs are used in these countries. In case of veterinary field, if suppose the antibacterial drug is used, so we should take care as a doctor or practitioner, we should take care that we are using the specific antibacterial drug for specific duration. But the main thing which we are not follow, especially the veterinary doctor, is suppose if we are using the antibacterial drug in food producing animals, so we are not follow the recommended withdrawal time. I mean, we can slaughter the animal if suppose the drug have withdrawal time is suppose 30 days or 28 days or 25 days. And after they, during that time, we will not use, suppose during the drug we are using against mastitis. So we should not use that milk for human consumption um, during that withdrawal time. So we should take care about that to minimize the resistance. Also, we should not slaughter the animal during that withdrawal time, because when the drug is excreted from the body and that duration, after that we will use that animal as a food. And the second is about the modeling, that we should work about. We should work on the pharmacokinetics and dynamics model in different institute to optimize, to re-optimize the dose that are used from several decades ago. From several year we are using that antibacterial drug. Okay, thank you.
So thank you so much, Dr. Ijaz. I hope all the questions are catered well, and there are some very useful comments from Dr. Ataullah Khan and Dr. Asghar Javed. So Dr. Ataullah Khan suggested there should be some proper antibiotic prescription guidelines issued by NIH to tackle the issue of irrational prescribing of antibiotics. So that's a very useful input from Dr. Ataullah, and and I hope all the questions are catered, and we are out of time, and it was very useful and interactive session. So thank you so much. Any other question? The session was going great, but due to paucity of time, we'll have to call it over till the next AMR Virtual Journal Club. So I thank you all for joining the session. And if there is any question, you can forward an email. Your question will be definitely there. So that's all for today. Thank you so much. Okay, take care, everyone. Allah Hafiz.
Hello. Hello.
अस्सलाम वालेकुम। हेलो, अस्सलाम वालेकुम। अस्सलाम वालेकुम। हेलो हेलो हेलो
वालेकुम सलाम।
हेलो हेलो।
जी जी वालेकुम सलाम।
हाँ सर, मैं ये क्वेश्चन पूछ रहा था कि एंटीबायोटिक रेजिस्टेंस की बात हो रही है, ठीक है सर। तो अभी जो हम जितना रेजिस्टेंस मतलब फील कर रहे हैं, ठीक है, जैसे इकोलाई में हम एक्सटेंडेड स्पेक्ट्रम प्रोड्यूसिंग इकोलाई हम फेस कर रहे हैं, ठीक है सर। और डिफरेंट एंटीबायोटिक थ्रेट होती जा रही है। तो मतलब ये क्या मतलब कैसे लग रहा है आपको कि अगले 10-20 साल तक हमारे को एंटीबायोटिक कारामद रहेगा कि या नहीं? हमें फिर मतलब किस साइड पे जाना होगा, होम्योपैथिक साइड पे जाना होगा या क्या करना होगा अभी?
You have asked some question. Can you repeat it?
जी सर, जी यस सर, आई एम रिपीटिंग। सर मैं एंटीबायोटिक रेजिस्टेंस के हवाले से पूछ रहा हूँ कि हम जितना ज़्यादा रेजिस्टेंस फेस कर रहे हैं, ठीक है, तो क्या ये आइंदा 10-20 साल तक हमारे साथ की एंटीबायोटिक बरामद रहेगी या नहीं? जितनी तेजी से रेजिस्टेंस जा रही है माइक्रो ऑर्गेनिजम्स में, जो मतलब म्यूटेशंस आ रही है, जो हमारे एंटीबायोटिक्स डिफरेंट है वो फेल होते जा रहे हैं, क्योंकि पेशेंट्स की भी मसाइल होते हैं, वो अच्छी तरह से यूज़ नहीं करते, प्रॉपर डोज नहीं लेते, ठीक है, या हम ओवर डोज दे देते हैं या मिक्सअप कर देते हैं सारे, तो उसी वजह से म्यूटेशन ज़्यादा आ रही है अभी।
Okay. Are you done?
जी सर, जी यस सर, यस सर, आई एम डन।
Javed, as I discussed earlier in my presentation, I told there must be a need of the time के कोई antibiotics के लाने पड़ेंगे.
जी बिल्कुल सर।
Already all around the globe antimicrobial resistance पे काम हो रहा है. Unluckily figures disturbing है, लेकिन we are on it. इसका ये इस बारे में बोला मैंने ये था कि ये कोऑर्डिनेशन में काम होगा, क्लिनिशियंस का, माइक्रोबायोलॉजिस्ट का, फार्मासिस्ट का और प्रेस्क्राइबर्स का। प्रॉपर अवेयरनेस की कमी आ रही है, स्पेशली कुछ सॉफ्टवेयर डेवलप हो रहे हैं ऑलरेडी अच्छा खासा काम हो चुका है पाकिस्तान में भी, एसबीएल पे, कार्बापेनम रेजिस्टेंस पे। नाउ वी आर गोइंग टुवर्ड द aminoglycosides and tetracycline groups. So inshallah in coming days you would hear the good news about the antimicrobial resistance regimes. So we are hopeful, we are doing the very best of us. So still the need of the time is that हमें बहुत rationally चलना चाहिए, एक proportion के साथ चलना चाहिए. There's no need of the antibiotics in viral diseases. There's no need of the prescribing the antibiotics in many mental diseases. ग्रोथ प्रमोटर में एज अ ग्रोथ प्रमोटर फीड रिटेटिव्स में एंजाइम्स यूज करने चाहिए, एंटीबायोटिक्स नहीं यूज करनी चाहिए. तो इस बारे में काफी लिटरेचर और बाकी काम हो रहा है. तो होप सो स्टे कनेक्टेड विद द साइंस, सो यू वुड हियर द गुड न्यूज़. Is there any other question?
सर मैं अगर मैं कुछ ऐड करना चाह रहा हूँ.
I'm really sorry, the time for the session is over. You can email your question and those questions will be definitely answered by experts. So Thank you so much for today, and please wait for the next virtual general club for the remaining questions and remaining discussion on the AMR. So thank you so much. Thank you. We are going to end this.